Good evening, everyone, and welcome to the ASPN American Society of Pain and Neuroscience Blurring of the Lines. We are so excited you've joined us this evening. We will be starting the webinar in just 1 minute to give everyone a moment to log on. Again, if you're just joining us, welcome to the American Society of Pain and Neuroscience. We will start the webinar in just 1 minute. Good evening. For those of you logging on and joining us now, welcome to the American Society of Pain and Neuroscience, ASPN's webinar tonight on Blurring the Lines. We are so excited you've joined us. We will start the webinar in just about 30 seconds to allow a few more people time to log on. Again, if you're just joining us, welcome to the American Society of Pain and Neuroscience's webinar. We will start in just a few more seconds. Good evening, everyone, and welcome to the American Society of Pain and Neuroscience's webinar, Blurring the Lines. Dr. Chakravarthy and Deer, take it away.
All right, thank you. Good evening to all of our friends and colleagues who are joining us across the country and probably all over the world. It's been a while since I've gotten to co-host this with my good friend, Dr. Deer. And, we talked about this concept about 3 to 4 months ago about how important and the changes that are happening in our space. And I can tell you, for a lot of the fellows that are graduating, there's a lot of questions around where's our space going? How am I going to really see the future of being prepared, going from an academic training program to a lot of private practices, and really getting to the bigger question around our relationships with our surgical colleagues. So, I'm really excited today. We've got an amazing set of faculty who will share their opinion. But this is really a major initiative and a commitment from ASPN to really get back to asking, what are the things that we can actually act upon, and getting from a conversation to things that we're really going to challenge our faculty tonight to say, what are the things you would like to see to help further this kind of bridging or blurring of the lines that we're seeing between, and really defining what pain medicine and interventional pain is. So I'm going to turn it over to Tim to say a few words, but really excited about the debate that he's going to have with our good friend, Dr. Falowski, and hoping to ask some good questions on that. Tim.
Hey, thanks, Krish. Dr. Chakravarthy and I first did a webinar for ASPN in April of 2020. It was on COVID, and we crashed the system. Over 2,000 of our friends joined that webinar. Tonight and over the next few weeks, we'll probably have a few thousand people view this one. I think we have about 750 people live right now. So it's a great time to discuss the future of our field. I was down teaching some fellows this weekend, and we were discussing where we were 5 years ago, where we are today, and really the evolution of the space, and to doing less invasive, more efficacious procedures to help patients in pain. So that's our goal tonight, to discuss both the issue itself, which we'll do first, and then, as you can see from our agenda here, look at what education and future training means as you come through fellowship and after fellowship when new things occur. Look at credentialing, policy and advocacy, and what's going on to make this so that patients have access, the role of society, and ASPN now the fastest growing and probably largest society in pain medicine around the world. Our goal is to make this international, so patients have access around the world, but also in your home community. And then Dr. Syed will share a consensus statement from ASPN on minimally invasive surgical procedures, which I think will be a valuable perspective when we go forward, when people get into things other than the important medical issues and start getting into issues that may be on the periphery that aren't appropriate. And our statement will stand to give the ethical and right ways to go forward. So, Krish, that's a summary of our night. I think it'll be a fun hour and 15 minutes or so. Hope all of you stay with us the entire time. It's going to be exciting.
Yep. And, we always recommend you guys, if there's questions that come up through the conversations, there is a point of this that's a live Q&A. Certainly enter your questions, and Dr. Deer and I will try our best to kind of address them to the faculty at the end. So for the first part, we're going to invite Dr. Syed to join me as a co-moderator, but we're going to do a very healthy debate on this topic that I think is across the country. We're all trying to figure out what is the role between pain and spine surgeon, how are we finding that boundary? So the context of this debate is Dr. Deere and Dr. Falowski will each independently present a 90-second argument for why they think interventional spine should be doing certain of the more advanced cases, versus Dr. Falowski, who may say it's really surgeons that should be doing these cases and not so much pain doctors. Hopefully, Dr. Syed and I will be moderating this, and obviously in live, who knows what things can happen, but we'll keep it as timid and kosher as possible. And then we'll ask each of them a question to kind of see if they have any other thoughts on this. So with that, I'm gonna let my good friend, Dr. Stephen Falowski, open with a argument for where he thinks surgeons should be the right folks doing these advanced procedures and why he doesn't necessarily think pain doctors are the right folks right now.
All right, well, thank you, Krishnan. I think we're probably going to realize after this debate that Tim and I are more aligned than we think, but I do think there are some areas where we differ. I think I'm going to open by saying I think it's kind of become obvious over the last few years, especially the last 5 years, that we're part of a changing landscape in interventional pain medicine, where the tools that are available to treat these patients has increased significantly, and I think pushed the skill set of many interventional pain physicians. And I think the days of what we used to call needle jockeys or pill pushers is a thing of the past. And I think a lot of the interventional pain physicians need to be on board and need to be knowledgeable of these procedures. And if they're not able to do them or not doing them, send the patients to people who can. I have an interesting perspective on how I look at these procedures because I was dual trained as a complex spine surgeon as well as a functional neurosurgeon, so minimally invasive procedures. And so I do think that many of these procedures, SI fusion, interspinous spacers, interspinous fusion devices, are very much well in the wheelhouse of interventional pain physicians. But I think probably one of the most important things, and I think is what's hindering it right now, is the lack of relationships and collaboration between interventional pain and spine surgeons. I think a lot of that stems on both sides. From the spine surgeon side, I think they worry that interventional pain is going to steal their cases. Two, that they may have complications that they can't deal with. And then three, if they have to go back in to fix it later, they no longer have a virgin spine. And I think a lot of this is education, but I also think a lot of it is the collaboration that doesn't exist right now between interventional pain and spine surgery. And I think there's an animosity there on both sides. So hopefully, at the end of this debate, I think I'd like to get across that interventional pain physicians should use their own judgment call. If they feel that this is within their skill set and they can safely administer this to their patients while maintaining a relationship with a spine surgeon, then I think they should absolutely put this in their practice. And I think there's a lot more overlap than we think that there was in the past. Lastly, I'll just say that there is a place for open spine surgery. As a spine surgeon, I still perform open decompressions, open decompression infusions, and there is a role for that. And the last thing you want to do is offer some of these treatment options to patients who should have been having open spine surgery. And I think that's why it's very important to have a relationship between interventional pain and surgery so that patients are not mistreated as well. So I'll now pass it to you, Tim.
Well, Stephen, that was a very balanced and excellent summary of the field. You know, I'm going to post a picture tomorrow on LinkedIn of Dr. Orfanos, my local neurosurgeon, doing a case together. We all have to scrub in together. We're very collaborative. His partners and I have the same relationship, and I think it can be a collaborative thing. So I think you and I are in agreement on a lot of things. Just a little background, when I was a med student, my local cardiologist, Dr. Warren, Dr. Carter, started doing this really interventional invasive procedure called a stent. And the heart surgeon was like, oh my God, they're doing stents and they shouldn't be doing that. And, you know, and that was the debate at the time. And as everyone listening knows, you know, stents became a major part of medical care. Now you still may need a bypass sometimes. Now, that doesn't mean you don't ever need a bypass. I think the corollary is very similar here. I think as we go forward, we need to make sure people are well trained. And I think the battle is going on of what we should do. The war is over. People want less invasive, less expensive, safer procedures. And now all we have to do is prove the efficacy in prospective studies. And we're starting to show that. I know Dawood is designing some studies right now for several of these procedures. So I think, again, we are all going to be doing less invasive, less expensive, more efficacious, safer procedures. And so minimally invasive spine surgeons will come our direction. Interventional pain specialists who are well trained will go their direction. We're going to meet in the middle realizing that many patients may need a larger surgery that the neurosurgeons or orthopedic spine surgeons should perform, and many patients may need smaller procedures that we should perform because we have the fluoroscopy training to do the procedures that need to be done. So I think it's gone both directions. We've seen surgeons come over here where they probably don't belong either. They don't have the proper training. So it's going to come down to what's best for the patient. What can we do to move the field forward? And Stephen, as you pointed out, and I think we're going to both end up in about the same amount of time here, this field's changed dramatically. And I think we all at Aspen are helping change the field because we're more than neuromodulation. We're more than injections. We're trying to encompass it so that any safe, efficacious, minimally invasive procedure can be done in the appropriate patient at the appropriate time with collaborations with our surgeons when there is a need for an open surgery, which does exist many times, and we can't forget that. So that's my opening statement. Darwin, Christian, back to you for any questions you have for the two of us.
Maybe I'll start with Steve. Steve, I've known you for a while, and I feel that as a spine surgeon, you've been very progressive in how you philosophically looked at the relationships you have with interventional pain folks. You've had a lot of us are your close friends. How do the challenge is that not a lot of surgeons have that same, in some ways, feel the same way that you do, that there is a need to bridge that gap. And they cite training, they cite time spent in looking at 6 years to 7 years in a heavy neurosurgery and orthopedic residency. Why should we see that space being kind of brought in through pain or the advancement? So what advice what helped you change your thinking and mindset to say, okay, I want to collaborate more with interventional pain and how I can be progressive?
I think a lot of it has to do with education. And I think the truth of the matter is most surgeons are not educated on these procedures. They don't realize that data already exists for some of these procedures, that they are extremely safe and efficacious. But I also think that's the fall shoot of not having the relationship between interventional pain and spine surgery. If there was already a collaborative relationship in your own community, in your private practice, with your referral base between you and the spine surgeon, you could be able to educate that person. And so I think where we're falling short is not having that relationship there already. And once you actually establish that relationship, I think spine surgeons would be more understanding of what is changing into interventional pain space. Now, that doesn't mean every spine surgeon is going to come around and say that they're okay with interventional pain doing spinal fusions. But the truth of the matter is, I think that it is in the skill set of many interventional pain physicians. The evidence is growing for it. We're demonstrating that it's a safe and efficacious procedure. Now it's just a matter of educating the spine surgeons that it's okay and that it doesn't there may be some overlap, but we're not taking patients from them. We're not causing complications they have to deal with. And we're not mucking around in the spine that's no longer going to be a virgin spine. So it all comes down to, I think, with a relationship and education.
Yeah, so I have a question for Tim. I think we're going to spend a lot of the program today talking about, the advancement of interventional pain physicians into kind of more traditionally surgical procedures. But one other thing I had a question for you is that I've started to see more traditional surgeons, orthopedic surgeons, and neurosurgeons starting to do more percutaneous procedures, injection-based procedures. And to be honest, I don't know what their background and training is on those kind of things. Can you give us your thoughts on maybe the reverse scope, I guess, of surgeons doing more percutaneous procedures?
Absolutely, Dawood. I think, those of us who are pain trained, we've done thousands of injections by the time we leave our fellowship, thousands. And when I do a lot of malpractice defense work around the country, it's much more common that I defend a injection than anything else. People get paraplegia, they get, all kind of different complications. So I think many times if you do large procedures for a living, you think the things that we do that are small are either so simple you don't have to put the care in, or so dangerous, or so lack of danger that it can be taken lightly. I think a lot of surgeons are thoughtful when they learn to do procedures. They may learn it from colleagues at a weekend course at NASS or somewhere like that. But I think it goes the same way it goes the direction towards the minimally invasive procedures. If you're properly trained and you respect the space and you respect the safety, I think it's certainly very appropriate that surgeons do those procedures. It all comes back in both sides to proper training, but it's even more than that. It's patient selection. You have to know when, if you have a very complex injection, the cervical spine, you probably need to send that to someone like one of us. If you have a SI joint injection and you know how to get into the joint, then it's probably proper for you to do it. the same way with us. If we can do a minimally invasive mild procedure, for example, decompress a ligament, that's great. But if they really have neurological progression, I need to get that patient over to see someone like Stephen or John Orfanos or James Harmon, someone like that. So it comes down to patient selection of what you're doing and proper training to do what you've decided to do. If you have both those things lined up perfectly, the patient will have a good outcome. And lastly, you have to think in an algorithm. Here's what we're going to do based on what we're seeing in the patient. If you're not in that spot in the algorithm, but you have the skills, you need to pass it to someone else. And that's why you have to collaborate and work together to help the patient as a team.
I really like that.
I'd actually like to chime in on that because I do agree with you, Tim, but I also think one of the major problems is that people don't know their own boundaries. Even on the spine surgery side, we are not trained with fluoroscopic imaging the way interventional pain physicians are. So we should not be doing complex injections, and I completely agree with that. But at the same time, the flip side is most interventional pain physicians are not trained on arthrodesis and fusion and bone graft material. So I think it's learning kind of where your skill set is and only applying the technology and procedures that you not only that you feel comfortable with, but you're knowledgeable about.
And I think that comes back a little bit to the importance of having continuing education, because if we get together like this and we discuss cases, I was at a course this weekend and Karen Patel and I were discussing DRG together. And we learned new innovations in the same procedure we were all doing, and we're talking to people about what they should and shouldn't do. So I do think that we have to, in some way, Stephen, coach ourselves and basically manage ourselves as a group or a specialty to make sure we try to set a standard that's appropriate and that people don't reach outside their scope. And if you're going to go and you're going to expand your scope, that takes additional training and proctoring and things of that nature. So I think we're saying the same thing. I think you said at the beginning we'd come closer together than apart. I think we're there, and it's because we care about our patients. That's why we're both together on this. And we also respect each other's skill sets, and we know we have a little bit different skill sets, and they're very complementary to each other, not adversarial.
Exactly.
Okay, I think that was an excellent closing remark. So kind of concludes our debate part, but I don't know, Dawood, if anyone last words, but that was really nicely stated.
Yeah, no, I think both these gentlemen did a really good job. I just had one question for each of you guys, because the name of this debate is blurring the lines. Is there a line, or is there not a line? I'll ask Tim first, and I'll ask Stephen.
Oh, there's definitely a line. I think the line comes back to your training. Example, I had a friend of mine say he was doing paddle leads recently. He's an anesthesiologist, and God bless him, but that's a line for me. I don't have the skill or quality training to do a paddle lead in someone. I would never attempt that. It would be malpractice to do so. So there's a line. It's based on your training. If you take an extension of training, though, something that I do frequently, Vertiflex, I'm doing a and there's another space where I can modify in a different fashion. That's an extension of my skills. So the line is when you go to a skill set that you don't have the base skill set to advance to that area. And that same is true for the surgical population community. If you're not good with fluoroscopy and you're trying to do a fluoroscopically guided procedure, you may get a triple complication. You could have opened up and done a great procedure, but now you're trying to do something you're not really skilled at. So there is a line. The line is based on the individual skill set training from, you have to have a baseline set of training to expand that training.
Great answer. Stephen, you care to chime in on that as well?
Yeah, I was actually saying, I actually agree completely with Tim. I think that there is lines and you don't want to cross those lines, but part of it is also knowing the limitations of your own skill set, knowing the limitations of what education you had, and if you did not have education in something, you have to seek it out, and then make sure that it's something that you're comfortable with in your skill set and that you can actually treat the patient adequately without hurting them. And that's, some of that is a little, looking back at yourself and understanding what you are capable of doing and understand what your education was. So completely agree.
Awesome. So I think this theme around education actually transitions very nicely to our next section. So if we could, thanks to Dr. Deere and Dr. Flowski, great answers. So if we could get Dr. Lee and Dr. Kalia on, that'd be great. All right. So I think Tim and Steve set up a really nice stage for, I think, this component of it, in terms of the challenges with where our academic education programs lacking, doing the right things, also in terms of the challenges with towards more intervention procedures. So have Dr. Colley and Dr. Lee chime in and give their thoughts on that.
Well, I was also at a program this weekend where we were among a group of fellows and a group of established clinically experienced interventional pain physicians, and discussing something similar. The question was asked, among those established clinical interventional physicians, how many of those people were doing procedures today in their practice that they did not learn in training, and every one of them raised their hands. I think that's inevitable and that will continue. And I believe that that's also the case in other specialties in the field of medicine. And so one of the kind of skills that I think that educational training programs needs to offer to its trainees is how to assess themselves for what they are prepared for, which was kind of the jumping point from our last section of the panel. And also when you're looking at a particular technology, how to assess if it is the right thing for your practice. And that includes looking at the safety and whether there's an appropriate patient population that you're seeing that would benefit from it, whether it's financially the right thing, whether it will kind of wash out in terms of the numbers, and absolutely the bedrock of efficacy.
I agree with that 100%, but I think I'm going to take back and briefly talk about the history of evolution of the pain medicine fellowship, right? So it initially started with the anesthesiology, physical medicine rehabilitation. Now it's open to neurology, psychiatry, and then recently diagnostic radiology. So ACGME does provide a set of standards to train upcoming new physicians in the comprehensive evaluation of pain medicine, but the field is evolving. As we know that the future is at the crossroads, and we're going through a disruptive innovation in the field where most of our procedures are minimally invasive spine and neuromodulation procedures. So it requires additional training. And as it was clearly mentioned in the previous panel by Dr. Deere and Dr. Falowski, I think it's important to have broach that topic and have that discussion again. About 5 to 7 years ago, we were talking about having a specific residency for pain medicine or adding a second year to our ACGME approved fellowship programs. Those debates never went anywhere, but I think we are at the crossroads now where we can probably think about developing a structured curriculum where we can offer a second year as only advanced spine, pain, and neuromodulation procedural fellowship for fellows who are interested in getting that training after they have finished their ACGME approval. And I think that's where the role of the societies are going to come into play. And that's the open discussion and forum to develop that curriculum and offer these therapies in a very structured manner to our fellows in training.
I love that.
Let me ask a question to Dr. Lee. So, Jennifer, I had a group of fellows recently in 3 different courses. Some fellows are trained so well to do so many things, and some fellows see very little things in their fellowship. It's just the way it goes based on who your fellowship program director is and all those things. How can we measure someone's ability to do things? And those who may be lacking, for example, let's say you didn't do any of a certain procedure, you didn't do kyphoplasty, for example, in your training. How can we assure that they get the proper training to ensure patient safety once they finish fellowship?
Yeah, I mean, I think you're talking about the kind of that transition between ending a fellowship and looking for credentialing to be performing these procedures independently. And, I think that if a person goes into a practice after their fellowship training where they're among other colleagues, that would be a perfect environment for there to be continued mentorship and some ongoing evaluation of their skills and the outcomes of their patients. I'm not sure that the answer is really in a number. You know, in anesthesia training, as many of us know, that you have to do a certain number of one procedure and another in order to kind of pass your training. I don't know that that's the answer in this instance, but I do think that our trainees need to be. I mean, I like the idea, Dr. Deere, what you were describing, kind of about having some reflection on what your foundational knowledge is. If your foundational knowledge is fluoroscopic, or if your foundational knowledge is otherwise, but having the training programs offer within them some development of insight, some skills for the trainees to develop insight into their own kind of safety boundaries. Because even if we do, require, a random, must have completed 5 Vertiflex procedures before they could be, considered independently sound. I mean, that doesn't take care of us when the next procedure comes around the bend. So I think we really need to. It's about instilling self-reflection and some framework for responsible self-evaluation.
I want to chime in here because I think Tim's point is a really important one. I think a lot of academic programs are struggling with this. A year is definitely not enough time, we feel, for fellows to get the basic fluoroscopy skills and still feel like there's an adequate assessment for them to say they're ready to do more advanced surgical procedures. And I think, Hemant, your point is a really good one. Is it another year of fellowship that gives academic programs the insight into saying, okay, somebody is or isn't qualified? I am curious, the comment that you said specific to societies and these cadaver labs, and do you think they are effective right now, or from a perspective of, are there changes that need to be done in terms of society or industry really looking at the critical evaluation of someone coming to a course and saying they're competent to go and apply this in their own practice?
Yeah, so I'm going to actually go back to Dr. Deere's question. So what we really need to do is we need to develop competency-based curriculums, and those curriculums will have inbuilt evaluation protocols which will allow us to evaluate these fellows. And coming back to your point, Dr. Chakravarti, I think right now, I think it's an overload of a lot of cadaver labs which are happening these days. I think it's high time now that there needs to be a discussion around developing a set curriculum for these advanced procedures, and someone has to endorse it. Someone has to make sure that there are set standards which should be followed, and those standards should be rigorous. Most of the fellowship programs through neurosurgery, orthopedics, and some of the really highly specialized surgical branches, they're non-ACGME recognized. So most of the curriculum is developed by the respective professional societies and the thought leaders in the field. I think we have a huge and really impressive opportunity at this point to be at the forefront and develop that curriculum and develop that platform to train these fellows who are interested in learning these advanced procedures. This will not be for everyone, but this will be specifically for people who are really interested in advancing their skill sets in these advanced surgical and neuromodulation procedures.
I have one more question for both of you. I think we have time for this one answer before we conclude the panel. So this goes to both Dr. Lee and Dr. Kalea. We have a procedure that's done by urologists and gynecologists, and I helped actually invent a device a while back that actually treats incontinence. It hasn't been used for pain, and it's a little different method of implant than what any of us do. It lives in urology. How do we decide when there's a procedure such as that lives somewhere else, and now there's a new indication, let's say for pain, pelvic pain? How do we decide who has the baseline skill sets to train to do that technique and who shouldn't do it unless they do a new fellowship? How do we decide that? That's the final question for both of you. Dr. Lee, you want to go first on that?
Yeah, so I mean, there are some foundational skill sets, and there are points where you can crosswalk over your skill set fairly easily from one activity to another. And I guess I have a little bit, I really respect what you're saying, Dr. Kala, about the ideal of having this very robust process of training and having such rigorous standards. I worry though about access. I mean, these are procedures that have the potential to help so many patients. And I worry about putting barriers to responsible, thoughtful physicians being able to use them because of limitations of getting through such a program.
So Dr. Deer, I think coming back to your question first, we actually, our field did see that happen. So about 50 years ago, there was not a single anesthesiologist or a physiatrist or a neurologist who was implanting intrathecal pumps. So these crosswalk happened with the development of the field of pain medicine and interaction and adapting those therapies and developing the safety of that therapy and making sure that a well-trained interventional pain medicine physician can implant the pump safely. So I think what you're alluding to will happen with the collaboration. And I think I'm more optimistic. I think right now we're struggling with, especially that example of urologists with urinary incontinence, with peripheral nerve stimulators having such great evidence for that therapy, or even sacral neuromodulation. So there will be crossover in that field, and I'm hopeful that we should be able to bridge that gap with collaborative approach.
Yeah.
Great answer by both of you. Thank you so much.
Yeah, absolutely. Okay. So I think this next part actually segues really nicely to a initiative that ASPN started, which was looking at suggestions on how best to credential potential providers that are in our space. Dr. Naidu and a host of other authors were very intimately involved in that, and it was a really nice work that got published. So I'm going to give the floor to them to kind of walk through that. I think, you know, Dr. Kalia and Dr. really specifically set up the importance of, should we look at more standardization? How do we look at all the different practices that are out there and the challenges around that? So give us some of your thoughts and what kind of was published on that, and we can certainly ask you some questions.
Thanks, Christian, and thanks, Tim, for giving us the opportunity to talk about this. This was a topic that I approached Tim about probably about a year ago, and really the inspiration for coming up with this paper was twofold. Number one, I was dealing with some of these issues in my own hospital, and then number two, Dr. Death. I think everybody's familiar with the podcast or the show, and really what you saw from that podcast or show was a surgeon who got through the system who caused quite a bit of harm. And I think you all know the punchline here in the story, and it's in the news even currently. And the question is, could that happen with a pain physician? And in many ways, the answer is more so yes, because it's not just a single neurosurgical track, which is pretty defined. We come from many different backgrounds, and even our parent societies don't really know a lot about what we do in interventional pain. So the biggest influence for this paper was that in my own experience, and I had an awesome group of authors, Allison being one of them, kind of come together to discuss the lay of the land and how credentialing is done for some of these novel procedures. And we'll get into some of those details as we go along, but I also want to pass it on to Allison to describe what she did for the paper as well. You are currently muted, Allison. Yeah.
Can you hear me?
Yes.
Thank you very much for inviting me on the webinar. Yes, so we worked on the ASPN paper, and we worked on putting together some of the core competencies that are required. So like the medical licensing, looking at what things large academic centers and institutions do for credentialing and privileging most interventional pain physicians. And so collaboration is key as well, as Dr. Falowski and Lee mentioned, but The Joint Commission recommends credentialing and privileging, and they're important and should be updated every 2 years. So we talked about incorporating some of that into our ASPN paper, and also incorporating more of the new guidelines and best practices put out by JCAHO. And for example, in addition to recommending certifications for advanced procedures that go beyond the core certifications that are currently being recognized, and the credentialing components as mentioned by Dr. Kalia, looking in addition to the core components that the Joint Commission has recommended, specifically looking at like the minimum number of patients being 200, which are new coming out. I think it was published July of this year. And then following evidence-based medicine practices and guidelines, having quarterly data collection on each of those providers, quarterly performance metrics, which should include surgical site infections, new neurological deficits, unplanned return to OR times, patient-reported outcomes was another one. And then once those competencies were established, organizations should then follow another set of guiding principles that continue to monitor providers with ongoing practice performance through retrospective evaluations, as well as external reviews from time to time, and including third parties. So it's not just a biased approach of just those people in the healthcare organization or people who may not be experts in the field, because I was with Dr. Gier, and we had excellent trainers. Him and Dr. Kim, but a lot of these places don't have people who are skilled in some of these interventional procedures that people are getting certified in, but they have no one to evaluate them. So in addition, having that third-party external review, and then finally, we recommended identifying procedural centers of excellence and expert trainers for some of those trainees to go to, and for peer review that can be implemented to help them with performance evaluations and quality improvement for ongoing training and new procedures and adding them into the organization or the system.
So great answer, great thoughts by both of you. Thank you so much for those. I have a question for you both, and I think it's really relevant to today's discussion on credentialing. And I'll start with Dr. Nadu and then Dr. Engel. You know, when we want to do a new procedure in our hospital, Dr. Kim's been there 25 years. He still has to go through credentialing, and we have to show that we have the basic skills to do that procedure. It may even have to be proctored. And I remember when I was chairman of ASA, physiatrists tried to get in to take the ASA, the ABA boards, and they asked my opinion, and I favored it. I thought if someone's well-trained, they should be able to do what we do now. Physiatry is a major part of pain, as Dr. Nadu knows. So the question becomes this: someone gets trained and they go out into their own office or into a surgery center. How can we assure, is there any way, and there may not be any way, that they have the same standards as someone who goes through a credentialing committee at a Joint Commission facility? That's really the question I think could be concerning for some of these evolving procedures.
Yeah, that's a great question, Tim, and it's a really important one, especially as we're seeing a shift towards a lot of our procedures going to the ASC setting, and almost all of our minimally invasive spine procedures are in that type of setting. As Allison already mentioned, that peer-to-peer review process is still extremely important in the ASC setting as it is in the hospital. So for our ASC, for example, we still carry on that peer-to-peer process, and we have a tight-knit group with our spine surgery colleagues. So they actually like to watch some of these newer procedures that I'm doing just to ensure that everything is going well, but also just to learn about them. That's not always easy. So a lot of the recommendations we have made and are going to make tonight are hard to implement for lots of reasons, whether they're barriers or in rural areas, you just don't have access to a lot of people who can do these peer-to-peer reviews. But you know, COVID-19 taught us something in that we could take advantage of technology. So do a peer-to-peer through, you know, AV communication with Zoom through your OR. I mean, there are a lot of opportunities for us to basically audit each other. And I think it's one of the most important things we can do going forward, because if anything that I learned from this paper, it was that we have all these pillars to try to observe what we're all doing. But really the most important thing we can do is, as Jennifer said, look at ourselves and then look after others. And we need to go through that constructive criticism process in a constructive way, and not beat each other down. If someone seems like, you know, they might be not safe or causing any harm, we need to figure out a way to step in and help them. Potentially they're, you know, not helpable, and we have to get them out of there and you know, basically say they shouldn't do those procedures, and that's okay. because the bottom line is the safety of our patients. Anytime any harm is inflicted, it's not just that patient, it's a ripple in the pond effect. It affects the entire field, because as you guys know, those kind of stories get out, and then people start denigrating our entire field. So I would say that it's just as important ASC, even if you can in the in-office setting, for some of these complex procedures to have that peer-to-peer review process.
A great answer. Dr. Engel, you want to add to that at all?
Yeah, my answer would be twofold. So we did this in cardiac surgery, where we did do Zoom type of sessions, but they had some like 3D 3D technology where we could educate people in Dubai doing cardiac surgery. So we have been doing this for years, just in other fields. So we could translate that. Second, insurance companies who already audit and make sure that we're doing things correctly and doing peer review. So I think working with them and making sure that there's like a uniform benchmark, because I think sometimes they don't always have the most up-to-date guidelines that they follow and determine some of our care. So I think collaborating with them is essential in getting to be influential with their key opinion leaders.
Yeah.
Krish?
I was going to say that if you haven't read that credentialing paper, I really would recommend taking a deep dive onto this. I think Dr. Naidu and Dr. Engel did a fantastic job summarizing some of the key points. It's a great start. I think, Ramo, you really highlighted, and same with Allison, we have to be creative in getting that information out there. I think the big challenge is there are a lot of great ideas. It just hasn't quite had the uptick on a national level. So, this is a great opportunity. So if you're hearing this webinar and you're going to hear it later, please take a look at that paper. It's really well laid out, and it gives a lot of rubric on suggestions that we would recommend as a society, but also for individual practices. Tim, anything else?
Yeah, and Chris, if you don't mind, yeah, I would just to summarize for those of you who didn't read it, and since some of these topics have been discussed in the previous sessions, really there are three major pillars for us going forward. And I think a lot of you are on this call who are part of academic programs. The first pillar being our fellowship programs. One of the things that's really challenging for those of us who are doing a lot of these novel procedures is looking around the country and seeing some programs are really adopting these technologies and others really aren't. And what we're seeing is a huge divide in our fellowship program. So if you're on this call and you're in an academic program, we need to balance that out so that we know that if you're a paying fellow, you're a paying fellow. Obviously, not everyone can do everything, but we really want to see some more therapy adoption. And really a big part of that is having the kind of conversations we're having with spine surgeons. So I encourage academic programs to do that and to really get those fellowships up there. The second pillar is really, the industry. They really need to protect their products, and I think there's a fear of maybe industry, being too aggressive about the education. But quite frankly, they're the ones who know their therapy the best, and they want to protect it. So, they're the ones in the OR with you, and of course they should be able to speak up if they're concerned. Obviously, there's some lines that we can't cross, but nonetheless still important. And the third is what we're doing tonight, society. So a huge thank you to ASPN and Tim and Dawood and Krish for doing this, because this is exactly the kind of dialogue we need. It's not just for us as physicians to be able to do these things, but it's also for our patients. We can't let these disagreements affect patient care. If your grandmother could benefit from a minimally invasive procedure, then great. They should be able to get it from the physician in their community and not being told, no, you can only have a major spine surgery. That's the only thing you're going to get. So those are the three major pillars for those of you who haven't read the paper.
I love that. Let me finish with this question. We only have a few minutes left, but this goes to both of you. We'll start with Dr. Engel. So I was with some fellows about 3 months ago that were training with Tim Lubenow and Kumar Bhuvanendran at Rush, and they'd finished that fellowship, and they had done so many things as fellows that I have no doubt their base, just like you said, Ramo, their base is great. What if I'm someone who's been out 3 years and I didn't do a fellowship with that type of fellowship, and I see a new procedure on a webinar that looks really great for my patients, but I have never seen it in person. I've never done it. Where does that person start with it? And again, we only have about a minute apiece, but do they start with industry? Do they start with their colleagues? How do they learn a new technique they didn't have any training for in fellowship? Dr. Engel, we'll go with you first.
I think it's essential to have good mentorship, also work with industry and make sure you're getting the right training, because they have things approved and very specific protocol that has been studied, and then having a mentor that you can work with daily. You can call for help for those, you know, where we blur the lines. What can I do here? What can I not do? And I have like a board of mentors, like, you know, 12 different people I can call on for different help for different questions. So I think that's kind of essential.
Great insight. Ramo,
Yeah, I would say that industry training, society training with certification, which I think that is something that Aspen certainly can and does consider. And then third, but certainly not less, is as Alice was saying, knowing your ecosystem. So ensuring that you have the right backup, the right proctors, the right peer-to-peer to be in the operating room with you in case things occur or complications occur after the fact. So I would say those are the three things I would take home.
Great job, both of you. Thank you so much. That was awesome. Great job.
Thanks, guys.
Krish?
All right. Now we're going to bring back Dr. Lee, Dr. Desai, and Dr. Kalia to walk us through some policy and advocacy and some suggestions. You've heard a really lively debate. We've carried you through some of the educational stuff. You've heard some stuff on credentialing. Your thoughts on where Aspen should really put their time and effort in terms of what is a really important topic in preserving a lot of these advanced therapies and the challenges for them. So I'll let you guys take it away.
Oh, if it's gonna be silence, I guess I'll go. So you know, I think this is a really interesting position. I think the prior speakers, I think, have set this up really well, and this is a fantastic and timely session, because I think so many of these things are happening real time. And one of the challenges with policy and advocacy is oftentimes on the clinical side, things are the horse is out of the barn, and on the policy advocacy side, we're trying to sort of talk to folks about things that are already happening and sort of educate them on concepts that are already occurring. So I think I was sort of jotting down some notes as the session went on today, and some of the things that came to mind is we need to continue to kind of double down on content, right? So anytime we go to Capitol Hill, for example, in Washington, D.C., or go talk to CMS or any of the other major payers that one might encounter, or talk to someone at the local, like the state house in their state or commonwealth, the more information we're armed with, the better off we are, right? So that's why the efforts to produce high quality research, the efforts to sort of put as much into data as we possibly can, so that we can go talk about tangible things with these folks. The second thing I jotted down was, you know, we need to continue to lobby. We need to get in front of folks, and we need to do it over and over and over again. It's not enough to go once. It's not enough to go twice. It has to be a continuous process. Right now, one of the challenges we face as a group is that there's almost too many voices in pain medicine. And, you know, we know that the bottom line when it comes to lobbying and advocacy is money, right? And so just as I was putting some notes together in preparation for this. So just in the 2019 two-year cycle, the American Academy of Orthopedic Surgery raised $4 million, right? And they donated $1.9 million in the election cycle in 2019. So it just gives you some idea of the context of the dollars that are being spent to understand better some of the work that needs to be done. And I think that brings me to the last thing I was going to say, which is that because of some of the things that are happening in terms of we have so many voices, we do need to continue to partner with each other, but also with the manufacturers who are coming up with these devices to get in front of folks and to talk about these devices early and often, so that we're able to educate and preserve, and also to expand access for people. So
I just thought that was a brilliant start. I think I want to take your comments, and I want to ask a question, Dr. Lee and Dr. Clay, and that is, which is more important, research or lobbying? Which is, if you had to pick one, you can't pick them both. You got to pick one. What would you pick? More research or more lobbying?
It's research. Yeah, I mean, we really have to stand on the truth of efficacy, and let that be the guide to our efforts. And so I think without the supporting research, it's an empty effort to lobby. And I guess I may be a bit of an idealist, but I do believe that we're going to have more success in our efforts if we really have undeniable data behind our requests.
I'm going to be a little pragmatist. I think lobbying goes a long way, and those therapies which are developed by research are going to die down if appropriate efforts are not put in to get those therapies accessible in the rural parts and the main street of America. So I completely agree with Dr. Desai's point and some of the points by Dr. Lee as well. But I think the challenge with advocacy and policy is it's a very it requires a lot of money, and I think we are a young society, and I think the key here is collaboration, and we don't need to reinvent the wheel. I truly believe in collaboration and not reinventing the wheel, especially in the field of advocacy and policy. So that's the key.
Let me ask you guys a little bit, two points, and I think both to Dr. Desai and Dr. Kalia. So we hear a lot about collaboration, unity, unified front. What are I think the challenge in that is, I got to be honest, when you look at our surgical colleagues, they're very, very unified in a lot of the things and have a very common, strong opinion about certain perspectives on certain procedures, who should be doing them, who should be not doing them. ASPN has certainly taken this lead in looking at this as an important part of how do we start to advocate and look at these procedures and stand up for the interventionalists that are trying to now bridge that gap. What are more practical ways to get other folks to buy into this vision? I think the big challenge is what part of the message isn't necessarily getting to that unified front. What do you think are the challenges, and what are suggestions you guys may have that maybe we take a different approach?
Well, I think that there's no doubt that money moves forces, but I do think that there are other shoestring priced efforts that can be effective. We can take advantage of the momentum that our patients can supply. Our patients can be advised to be calling their insurance commissioners when they are being denied procedures that we can show them have good evidence and safety. And our patients can be advised to call their insurance companies and make noise there as well. I think providers can be accessing huge numbers of patients through Facebook interest groups or other social media interest groups, and then those can be mobilizing and making noise to their senators and their state representatives. And I do think that we need to be taking advantage. Our patients, it's equalizing, right? Where we have shared decision making and shared ownership of those decisions and in our practices with our patients, and they can be very, very strong self-advocates and help to move the needle on these issues.
So I think the one thing I was going to add, I think I agree with Dr. Lee that I do think research forms the underpinning of a lot of the things we'd like to do, and we sort of have to build upon that foundation. So if you build a house, you don't build it from the top down, you build it from the bottom up, right? So, and research is sort of that foundational piece. But we also know, and for those people who are on the call or attending, anyone who's met with an insurance carrier knows that the goalpost can move at any time. Meaning that you can come up with the best study, present it to the CMO of whatever insurance company you present to, and they're not obligated to cover something just because you did the study that they asked you to do 3 years ago. They can change those goalposts all the time. But one thing that we have going for us, I think, compared to the other specialties, and you pointed this out, the aggregate group, there's 29,000 people who went to the last AAOS annual meeting, and 39,000 people are members of the American Academy of Orthopedic Surgery. We can't really compete with that from a size perspective, but we are much more dynamic and much more nimble, right? So we have the ability to plug into a multitude of different platforms and ways to get to lots of different stakeholders, which maybe they're not as astute as, because it takes a lot. It's much harder to turn an aircraft carrier than it is to turn like a cruiser. And I think we have to sort of capitalize on that.
So, I think, first of all, Dr. Desai, your comments are, man, rock star comments. So we got to get you more involved, man. But I will say that I have a question for all three of you, and that is, in my career, I've seen some landmines in this area of policy and advocacy. I was on a society's board that advocated opioids. I mean, I'm not anti-opioid in that someone needs it, but they were pro-opioid, way beyond what I thought was reasonable, and it led to them having a lot of problems later on. I was on another society's board that got so into advocacy of reimbursement that many young people thought they lost their focus on science, right? So how do we do this without losing our focus on science, on efficacy and safety? I mean, to me, that's what I really vision Aspen being the most about. So any of the three of you want to take that question? I think, how do we avoid landmines and do the right thing?
Strike a balance.
I would say, follow the vision. That's why every successful organization has a mission statement and vision delineated by further goals and objectives. So I think the vision and the mission statement of Aspen will guide us and use appropriate policy and advocacy efforts to advance the field and make sure that these advanced spine and neuromodulation procedures are accessible to not only big markets, but also at the grassroots level. That's where I think the key is. Small pockets where they have restrictive covenants and providers are struggling. I just got a email like yesterday in the southern tier of in New York State, where DRG therapy is considered investigational by one of the third-party administrators of Blue Cross Blue Shield. But we have level 1 evidence now on dorsal root ganglion stimulation, and that therapy is considered investigational in that LCD in that region. So that's abominable, and I think that's where the role of societies and grassroots effort and partnering with the industry is going to be really, really critical in making sure that the access to these therapies is made possible.
Very nice answer. Yeah. Dr. Lee, Dr. Desai.
Yeah, I love your answer about really staying true to your mission statement as a method of balance. And then I also think that having a diverse and large group of people participating in the policy and advocacy committee as well will help to prevent, the group from sort of running down a certain rabbit hole and getting too hyper-focused on a single effort.
I think I might make make a little bit more of a controversial statement just for the sake of being maybe getting people a little riled up and talking about things a little bit more. But I think one of the things, and it ties together some of the comments from previous, but I do think we need to show a little bit of restraint. We need to be good at policing ourselves, because the more, especially when you start something, the more outliers there are, the more problems there are, the harder it is to make headway. Two, I think it wouldn't hurt, someone posted earlier a question about people posting pictures online of procedures that are maybe not done properly or incorrectly. I think it wouldn't hurt for us to have a social media guidance document that says, hey, because we're not acting as employees of companies when we post things, we're acting as people are looking at those posts as medical advice sometimes, so we have to be a little bit cautious. And for everyone who's looking at that to say, how great work, you did a great procedure, there could also be someone looking at it from a Medicare perspective or a payer perspective saying, wait, why are you doing that, right? The other thing is, and I think this is one area that Dr. Naidu talked about, ASCs. I think that's actually an incredible opportunity, because all along we talked about, and maybe the first session between Dr. Deere and Dr. Folofsky was about this idea that historically there's been misaligned incentives. But by working in facilities like surgery centers, we're aligning those incentives, right? So we're taking people like surgeons and pain doctors and saying, hey, you can be on the same team and you have the same ultimate interest in mind. We just want to make sure that the folks doing these procedures are doing high quality work. And as long as they are, there's nothing but reasons to collaborate and to build bridges.
I love that.
So did I hear you volunteer to lead along with a few other younger people at social media document creation? I think you're right. People posting things all the time that drive me crazy, because they really danger them for patient, maybe loss of confidentiality in HIPAA, maybe for inappropriate procedures, maybe inappropriate techniques. So I'd love to create that document. If you would lead that, that'd be great.
Happy to help.
I love volunteerism. Thank you.
All right. I think that was an awesome section, really wonderful thoughts. And it makes total sense about, you guys have spoken a bit about balance and vision, so which leads right into our last section about the role of society. So if we could get Dr. Peterson, Dr. Kali, and Dr. Syed on that.
Hello, Erica.
Good evening. What a great discussion.
Yeah, absolutely. All right. Erica, you want to say the first words? I think you've heard a lot about what is the vision of Aspen, how important it is for maintaining this balance. Your thoughts on, now as president-elect and getting to the point of looking at our society and how it's shaping our space. Your thoughts first.
Well, thank you very much again. I think this is a really important topic, and our speakers have all had some really excellent points. There are a lot of different aspects that have to be taken into account when it comes to leadership. And Dr. Kali's comment about looking at the mission and what our goals are is really important, because a society is integrated from many different perspectives. We have a diversity of experience, we have a diversity of practice settings, we have a diversity of specialty backgrounds. And so whatever we do as a society has to have some degree of unification to it. And the best way to consider that is to say, well, what are the fundamentals of what we're trying to get here? And I think we can boil it down to something Dr. Pope and I were talking about recently, which is, number one, we know we have an educational mission. And so what we do is fundamentally educate at every level, from patient to trainee to practicing clinician to those that are perimedical, whether it is administrators or reimbursement as well. The other thing is exposure, the idea that we identify what these breaking edge techniques are, and then find ways to ensure that our members and other people practicing are exposed to those and understand them, and understand the indications and the safety and the risks of applying those new techniques, some of which we already discussed tonight. And then finally, it's about protecting patient access. And that includes insurance reimbursement, it includes education awareness, but it also includes how do we get these advances into the disparate geographic environments where people need access to those. So ultimately, we can't say that we become an enforcing credentialing body. We can't say necessarily that we are going to be the contracted trainer for any one specific thing, but we can look at this overarching piece of how we can communicate, use our network of experts and members in order to facilitate those three goals and accomplish what we hope will do, is to build this unified approach, and also then facilitate some of the techniques that help us to be savvy in the relationships that each clinician has with other specialists who are either in the same space or adjacent to their space as part of that.
Yeah, I mean, I think, it's hard to follow Erica's very eloquent answer there, and our president-elect being, a neurosurgeon, I think speaks to the diversity of our society. It's not just a bunch of pain doctors or a bunch of neurosurgeons. We have a very diverse collection of clinicians and neuroscientists. And when I think about what the role of societies is, the saying that you always heard, if you're not at the table, you're on the menu. So if societies don't take the lead on figuring out, what we should and which we should not be doing, someone else is going to make that decision for us, whether it's payers, whether it's, maybe specialists in competing, specialties that may see this as a turf battle. So I think really societies like Aspen that have a diverse collection of clinicians really should be taking the lead in deciding kind of where this line really is. So this line's not as blurry. The field is advancing so quickly, and you really need a nimble society that, is not like, Dr. Desai made some great points about, the size and the scope of the orthopedic society, but they're so large that they really can't respond to some of the things that happen so quickly in our space. Just look at the things we've been doing just from, today to like 3 years ago. It's advanced so quickly. So,
Dr. Kalea, let me ask you a follow-up question on Dr. Peterson, Dr. Sayed's comments. Aspen's done a lot of great things to change the space, I think, in 3 years, and we keep doing that. We're working hard. What's the next action points we need to take, in your opinion, as a society to continue to shape the space?
I think I agree with Dr. Peterson and Dr. Said's comments there, and sticking to the vision of the society where we advance the mission of education, advance the mission of research, and provide this incubator where innovation continues to flourish, and also with our advocacy and policy efforts, make sure that these therapies reach the main street and the grassroots level. So it's a combination of all those things, I think, which will make sure that we carve the path for success for our members.
Krish?
No, I mean, I think that's important. We've talked a lot about some very practical things that came from faculty, whether it's social media guidance to, I think the hardest part is distilling a vision down to actionable things. Maybe I'll ask this to specifically to Erica and Dawood. Give us 3 goals you want to see ASPN accomplish policy and advocacy wise this year. Or at least something that, is it increasing the training programs for our members, something that can take palatable, or including fellows earlier. I know, Erica, you've been a big proponent of this P2P program, which has been a really amazing way of capturing some of the more younger fellows who are training. Do you see that as a way to help in kind of bridging this educational gap that we've kind of clearly articulated? Your thoughts?
Yeah, so the Poster to Podium program is something that I wanted to innovate beyond just the standard mentorship model that's existed in other societies, and talk about developing early career leadership, whether that becomes research, industry innovation, or educational leadership. And so our first class is going through that, and hopefully that this will be a successful pilot year, and something will then perpetuate and we'll be able to expand, because there is a need for not just attending a course and applying a couple of pearls and tidbits from the course and then to your own practice, but actually thinking about what that means for a larger leadership impact, and how then that translates to a group of larger people in a society that you work with. The other area that I see is really valuable is to create a bigger branch actually into the neurosciences. Our first 3 years as ASPN has been a lot of the P part, and I'd like to see more of the N part, and whether that means reaching out to the basic science bench researchers to continue to expand our membership and figure out how we can collaborate in basic research in pain and neurosciences, or in translational areas that then take us to the next generation of innovation. Because part of what defines the arena in which we practice is how those innovations and discoveries are made. And if we are driving some of those discoveries through those partnerships, then we also are part of the conversation as to how those become implemented. It goes to what was said before, which is don't take it off the table. If somebody else takes it away from you, you don't have it anymore. But if it's ours and we claim it and we develop that through these partnerships, I think that we have a lot of opportunity to innovate in a way that impacts a significant number of patients. And ultimately, that's what we're here for, is that we want to attack chronic pain that otherwise doesn't respond in ways that can branch out and impact significant numbers of new patients. And so that's where I'd like to see us go.
Yeah, I mean, I think for me, the biggest roles, I think now that we look at our society now has quickly grown from, 4,000 active members and kind of 7,000, you kind of consider some of our casual members nationally, internationally. We have a pretty big voice already. One thing that, I hear from all of our members and myself on a day-to-day basis is access to these therapies continues to be a struggle. And so I think what I would like to do, and have our society do is continue to be involved in multiple facets and ways to increase awareness and access to these therapies, because it doesn't matter even if the neurosurgeons say that we can do this procedure. If Cigna or Humana says this is experimental and you can't do it, it doesn't even matter, because the patients can never get this. So what can we do as a society to increase that access is really, I think, the most important thing. And I think that's why the stuff that Tim has done over the last 25 years or greater with research and literature and best practice, those are really, I think, the key first steps that we can do. Then all the other things happen, the policy, the advocacy. So really, I think that's the major goal, because we really want to help our patients. So I think really increasing awareness and access really need to be our biggest goals of a society.
Hemant, anything to add before I give it to Dr. Dare?
No, I think that was perfect.
So here's our last question, and then we're going to have Dawood show us a policy we've created for Aspen on minimally invasive surgeries. I think you'll be intrigued by his 7 slides, and then I'll have Eric and Mott give a comment on his slide presentation before we close, along with Krish having the final word of the night, our Vice President, Dr. Chakrabarty. There's a lot of societies out there, you know, and when Dawood and I created this one and then partnered with people like Erica and Jason. Jason can be here tonight, by the way. He has a patient in the emergency room. Dr. Pope, he had to go check on a patient, so he apologizes to everyone. But here's the question for you. There's a lot of societies. Our society's grown, as you said, Dawood, you know, somewhere between 5,000 and 7,000 people now. The question becomes, you know, where do we need to go next? Should there be 25 more societies? You know, someone mentioned, Dr. Desai mentioned orthopedic surgeons have a couple of big societies. We have the splintering in our field. What can we do to make Aspen more impactful and to maybe make the splintering be less harmful to our space so we can get that access? So I'll open that up to Erica and Mont, and then we'll go to Dawood for his slides. Did you clear?
I think that we're thinking, but I would say that one of the advantages of a conversation like tonight is that we're starting to talk about how we bridge, and even the title of Blurring the Lines, the posture of collaboration, the idea of extending your hand across the divide, that already is something that is an important place to be, because it comes from a place of confidence and humility at the same time. And I think that that's a very appropriate place to be. We're going to find that not every person wants to be a part of ASPN and doesn't necessarily like the mission or the posture in which we talk about things. But ultimately, I think that we need to continue to branch out and figure out where we can have alliances that, again, come to the fundamentals of patient care and the access that they need.
I'm going to just say 3 pillars: clinical innovation, research, education. And I think those 3 pillars will form a solid foundation, a solid path, and you know, people will follow, and we will create the path for success. And I agree, collaboration is the key, and not reinventing the wheel. And I think the mission of the society will guide itself.
Great answers. Dawood, you want to show us a few slides and then we'll wrap up.
Yeah, absolutely. I think we can. Sure, if Michelle or Stephanie could load this up. So just some background on this. So again, it comes to, you know, what I said earlier, you know, if you're not on the table, you're going to be on the menu. So the Aspen Executive Board really took it upon ourselves to really develop a major society consensus statement that deals with minimally invasive surgical procedures. So again, once we started to tackle this topic, we learned very quickly that really we needed to set some definitions. It really wasn't even established what a minimally invasive surgical procedure was or was not, in addition to all of the things about scope and who should and should not be performing these procedures. So I'm just going to take you through the consensus statement here and show you some of the high level things. So again, we named this the Aspen Position Statement on Minimally Invasive Surgical Procedures. So the background was that minimally invasive procedural techniques continue to advance. We all know that based on today's program and all the stuff we've seen over the last few years. Many of the recent surgical approaches have been geared toward minimally invasive image-guided approaches. And we know that there have been recent position statements by surgical societies in which there has been some inconsistency from the modern practices without multi-specialty input and really a lack of evidence-based referencing. So we saw that there was kind of some other things out there that we really didn't quite agree with. So next slide. So here's the purpose. You know, we know that Aspen is really what we consider the leading society on minimally invasive surgical procedures. We wanted to incorporate multi-specialty input from anesthesiology, orthopedics, family practice, neurosurgery, neurology, radiology, physiatry, and psychiatry. We wanted to define what a minimally invasive surgical procedure is, and we also wanted to take some time to say what a minimally surgical procedure was not. We wanted to provide some guidance on training requirements for those performing minimally invasive surgical procedures. We also wanted to provide some peer-reviewed evidence to back our claims and our consensus statement. And then we wanted to provide guidance on comprehensive care teams and how to manage complications of these things. Next slide. So really, we came up with this, and this was again taken from multi-specialty input. We had orthopedics, neurosurgery, anesthesiology, physiatry, radiology, neurology, amongst other specialties as well, that helped us define what a minimally invasive surgical procedure was. So what we came up with was that percutaneous, or a minimally invasive open approach with assistance of image guidance. These procedures should have minimal risk for major perioperative complications such as blood loss requiring transfusion, major neurological injury. We did acknowledge that major complications can occur with minimally invasive surgical procedures, but the published rates should be minimal. These typically should be done in an outpatient setting, but certain clinical scenarios may justify inpatient settings. So again, you can see that the definition does have, you know, some substance to it. Next slide. So here are some examples of current minimally invasive surgical procedures. Percutaneous interlaminar lumbar decompression, interspinous decompression and fusion devices, minimally invasive facet fusion procedures, minimally invasive posterior sacroiliac fusion, ablative therapies, vertebral augmentation, SCS and PNS implantation techniques, intrathecal drug delivery implantation, and augmentation of the intervertebral disc. Now, again, this was not supposed to be an exhaustive list, but we brought some high-level examples of things that are commonly being performed by our members. Next slide. We also thought it'd be very important to define what is not a minimally invasive surgical procedure. We really did not want this consensus statement to be a carte blanche open season for people with the unnecessary backgrounds to kind of start doing things that were well not within their scope. So things such as, and again, this is not exhaustive, but things like open laminectomies and complex spinal reconstruction are completely not within the scope of what this consensus statement is about. Next slide. So we took some time to talk about the training requirements. The ASPN consensus statement says that core training in the fields of anesthesiology, orthopedics, neurosurgery, orthopedics, physical medicine, radiology, and interventional radiology. Physicians should have additional subspecialty fellowship training in pain medicine and spine. ASPN also acknowledges that there may be also other physicians from core specialties that may perform minimally invasive surgical procedures with appropriate fellowship training. Next slide. So our conclusion, physicians performing minimally invasive surgical procedures should do so in a comprehensive care team so that appropriate referral for both operative and non-operative complications can occur appropriately. We thought that was pretty important. You know, we spent a lot of time talking about, you know, the operative complications, but really these multi-care teams also need to have non-operative complication managed. So things like appropriate psychological referral and those things really need to happen when you're performing these procedures. We don't really spend a lot of time talking about that. ASPN questions the validity of any other specialty society consensus that does not incorporate multi-specialty input. And we really think that this is a living document and updates we made when deemed appropriate deemed by the ASPN Executive Committee. And we've now housed this consensus statement on our website at the website here, right here. You can access the full statement with the references here. So that's our consensus statement. I welcome anyone to kind of follow up with any type of input or questions. So thank you very much.
Great job. Thoughts, Krish, Hemant, Erica, anybody have any thoughts on that?
Excellent. Erica.
I think this is a really great step in the right direction. It's important for a society like ASPN to come up with a consensus statement on this very important topic. We have seen a lot of arguments kind of thrown around recently in the last couple of months through different other societies, limiting the access of these therapies to well-trained interventional spine and pain physicians. So I think this goes a long way in endorsing the field and the therapies which we use to help our patients, not only their pain, but also their function and quality of life. So thank you.
Erica, any last
Well
thoughts?
done, Dr. Syed. Thank you for presenting that. I think it really underscores with this that not only is this a guiding principle for today's procedures, but the fact that this is able to bend to innovation is a really important part of it. The other thing is that drawing absolute hard exclusions. It provides some guideline guardrails really as to what's safe. So some of what we touched on, what's posted on the internet as a valid case or who has a lot of complications, those are people who are not practicing within the spirit of, not actually within the definition of these guidelines. And it facilitates a discussion of how we maintain the reputation of performing safe, effective care for our patients. So thank you very much, Dawood, for leading that.
Absolutely. So I want to say a fantastic thank you to all of the faculty tonight. For all the people listening, there was hundreds of questions on the chat box that we probably can get to. And I think one thing you guys would get a sense is that the folks at Aspen are really thinking, I think that ultimately the key themes are patient first. You know, whatever we do, whatever therapies we develop, whatever the research, advocacy policy is putting patients first and their safety and the efficacy. And I think there are a lot of things I took away today, and one of the whole hope was to come to things that are actionable, whether it was suggestions on social media guidance, looking at our consensus statement, sharing it with our surgical colleagues, certainly getting down to other ways to educate more innovatively. I think it's clear that we have more work to do. We've done a lot in the last 3 years, to Tim and Dawood's credit. I mean, for one of the largest societies now, we're really inclusive, we're looking at diversity. So I think my key takeaway for a lot of fellows, as well as younger physicians who are looking for a place, this is the point of starting that conversation. Don't fear reaching out to the folks that are in the leadership. Any idea is a good one. And I think we have, you know, the comparison that I keep hearing is pain is what the cardiologists were dealing with in the 50s between coronary bypass and the era of stents. And I think we're starting to get into that idea of where we find that bridge, and we're going to be hopefully working together in a collaborative, multidisciplinary way. But really excited with, I think, the vision and the leadership that we have, and I think it's only going to get better. Tim, any final thoughts?
Yeah, you know, I think almost everyone on this panel tonight I met when they were fellows or residents, and I told everyone the same thing back then, and you know, it still exists today, and that is, if you put patient safety and efficacy first, you'll do well in your career. And I think when we think about blurring the lines, you heard Dr. Pulaski and I debate this in the beginning, but you know, he and I have blurred our opinions close together now. And it comes down to patient safety and efficacy. So those of you who want to expand your practice, there's Dr. Pulaski now, speak of the devil. But if those who want to expand your practice, I think it's very important that you hold yourself to a high standard of training, a high standard of getting mentored, and then a high standard of outcomes. You have to watch your outcomes and make sure that you're doing what's best for your patient. If you don't hold yourself to a high standard, you should not do that new method because it requires excellence. You have to demand excellence of yourself, because if you don't demand excellence of yourself, you'll never achieve it. No one can make you have excellence, no peer review, no colleague. You have to do it. And I think you can do it, and you have help to do it. Look at this panel we're looking at right now. There's so many great people out there willing to help you and mentor you. So, Krish, I don't know if you want to ask any final questions to the panel before we close. We have 7 minutes left if you would like to ask any other questions, but that's my last comment of the night.
Yeah, I don't know if anyone wants to share any last comments, open to anything you guys want to leave the audience with, but take it away if anyone wants to add anything to that, or else we can close early. Okay. All right. Well,
you want to go over the CME and things? I think there's a few slides on CME and things to close with.
Yeah, so this is for any of the folks wanting to claim CME credit from this event. Give it a few minutes. We can go to the next slide now. And you know, this will be, I think you guys can access this on the website also. And coming up, I think Dr. Deer, Dr. Toba, and Dr. Syed will be moderating session 3 of the ASPN, looking at radio frequency for the joints on December 6th. If you guys can join them, that'd be great. And on December 15th, we're going to be talking about the next big thing in interventional spine and nerve treatment.
So I'm really stoked about this one. We're going to have about 40 people for 1 minute each, giving what they think the next big thing will be in our field. And then we're going to have about 20 seconds for someone like Chris or Erica or Stephen, Jennifer, Dalwood to ask them a question that will make them squirm based on their answers. So our goal is to give your idea and then take the hot question coming in about that idea. So I hope you can join us on December 15th for that, what I think will be a very entertaining 90 minutes.
Yes. All right. And so obviously, you know, we've talked a lot about education. Very important you guys get these dates down. Obviously, Innovation Summit and the data reveal in January 7th through 8th at Vegas. All of the executive board, as well as all the wonderful folks who are helping to plan that. I think it's going to be a fantastic event in terms of some of the newer therapies, as well as reinforcing for fellows who still want to get more hands-on. Great opportunity, as well as the think tank and the important annual conference that's going to happen July 15th through 17th. So, you know, we understand how important education and the training component of it is, and we're doing our best, I think, next year to fill as many ways to get you that information. And if you want to add anything to that, Tim, but.
Well, I do think I do want to add. So yeah, I hope everyone can join us. I just had I've had 2 different fellowship directors contact me, one by email, one by text, who are excellent people in the country, and they think that we probably need a follow-up discussion on this, and I'm probably going to invite both of them to join us maybe in January, to how difficult it is to train someone in 1 year to do all these things. And I think so. We don't have time for that now at the end of our session, but I think, again, I got a text and 2 minutes later I got an email from 2 people I really respect, who are both still on this webinar right now. I just read both of them. They're both excellent points. I think, Chris, we should have a follow-up on this to look at the challenge of training a fellow in 1 year to do anything like this. It's so hard. And I think we should have the fellowship directors on to discuss that in both neurosurgery and in physiatry and in anesthesiology.
So, agreed.
Very good. Well, with that, good night, everyone. Thanks for joining us. I think it's been a great night.
Good night, everybody. Thank you.